So I invite our first speaker to the podium is Sophie Liem. She's going to give her presentation on Pessaries in multiple pregnancy as a prevention of preterm birth, a randomized clinical trial. Okay.
Thank you, Dr. Menard, members and society for the opportunity to present our study, the ProTWIN trial. As you all know, women with a multiple pregnancy are at increased risk for preterm birth. In the Netherlands, about 50% of women with a multiple pregnancy deliver before 37 weeks of gestation, of whom even 9% deliver before 32 weeks of gestation. Preterm birth requires intensive medical care and is associated with a higher risk of perinatal mortality and morbidity. Interventions such as vaginal progesterone, 17P, bed rest, or cervical cerclage are not effective in preventing preterm birth in multiple pregnancies. The pessary was introduced in 1959. Since then, several studies suggest that the pessary could prevent preterm birth. However, most studies were small and non-randomized. The pessary is designed to move the weight of the pregnancy. There are different types and sizes available. The pessary is placed with a smaller diameter upwards. The Arabin pessary is most often used. So, preventing preterm birth remains a major challenge in obstetrical care, and therefore we conducted a randomized controlled trial to evaluate whether the cervical pessary could prevent preterm birth in multiple pregnancies. The study was performed in 40 hospitals in the Netherlands that all collaborated in a nationwide consortium for women's health. And as you can see, our small country was covered by the pessaries. Due to the nature of intervention, the study could not be blinded. We included women with a multiple pregnancy between 12 and 20 weeks of gestation. Exclusion criteria were known congenital disorders, stillbirths, early signs of TTS, or placenta previa. Women allocated to the pessary group had the pessary placed between 16 and 20 weeks of gestation. The pessary was removed in the 36th week of gestation, or in case of premature rupture of the membranes, vaginal bleeding, painful contractions, or patient's discomfort. Both groups received similar obstetrical care. Our primary outcome was a composite of the poor perinatal outcome, containing the following components. Secondary outcome were time to delivery, preterm birth rates before 32 and 37 weeks of gestation, days of admission in a neonatal care unit, maternal morbidity, and maternal admission day for preterm birth. Our sample size calculation was based on a reduction of the poor perinatal outcome from 12.4 to 6.7%. Women with at least one child with a poor perinatal outcome were considered to have the poor perinatal outcome. We needed 400 patients per group. Analysis was done by the intention to treat principle. Time to delivery was evaluated by Kaplan-Meier analysis. We conducted pre-specified subgroup analysis for women with a cervical length below the 25th percentile, measured between 16 and 22 weeks of gestation, and equal or above 25th percentile. These are the results. 813 women were randomized. 403 women were allocated to the pessary group, 23 of whom never received the intervention due to different reasons. 2 women were lost to follow-up, leaving a total of 400 women included for analysis. 410 women were allocated to the no pessary group, 3 of whom were lost to follow-up, leaving a total of 407 women included for analysis. This slide demonstrates the baseline characteristics. There are no differences between the groups. However, I'd like to point out that we had more cervical length measurements in the pessary group, 81% versus 71%, and that the mean cervical length was similar. These are the primary outcome of our study. There's no difference between the groups. Poor perinatal outcome occurred in 13% in the pessary group and in 14% in the no pessary group. No differences were found for the individual components of the poor perinatal outcome. The same results apply for time to delivery. On the x-axis, you can see the gestational age in weeks. On the y-axis, the proportion of women pregnant. The orange line indicates the women with a pessary, and the black line represents the women without the pessary. The curve indicates that there is no difference in time to delivery. Secondary outcome follow exactly the same pattern. There's no difference in days of admission on a neonatal intensive care unit. No differences between maternal morbidity, and no differences in maternal admission days for preterm birth. So far there seems to be no difference between the groups. But as mentioned before, we conducted pre-specified subgroup analysis for women with a cervical length below the 25th percentile. This graph demonstrates the distribution of the cervical length. 25th percentile was found at 38 millimeter. To evaluate subgroup effects, an interaction term between treatment and cervical length was added to the regression model. The p-value for interaction was significant. And these are the results of our subgroup analysis. Poor perinatal outcome occurred in 12% in the pessary group versus 29% in the no pessary group, with a relative risk of 0.4. The component where we found the largest difference was death before discharge. This occurred in 3% in the pessary group and in 18% in the no pessary group, with a relative risk of 0.14. On the left side, the Kaplan-Meier curve for women with a relative short cervical length. Again, clearly indicating a prolongation of pregnancy in women with a pessary, the orange line. Furthermore, gestational age at delivery was 36 plus 3 in the pessary group versus 35 plus 0 in the no pessary group. Treatment with a pessary significantly reduced preterm birth before 28 weeks, 4% versus 16%. Before 32 weeks, 14% versus 29%. And there were less preterm birth before 37 weeks, although this did not reach statistical significance. This graph demonstrates the perinatal outcome for our subgroups. On the x-axis, again, gestational age in weeks. On the y-axis, the number of children. The blue bars represent the children with a healthy outcome. The orange bars are the children with a poor outcome, and the red bars are the children that died. These are the results for the no pessary group. And these are the results for the pessary group. Again, indicating more perinatal deaths due to preterm birth. So as a result of our finding, we concluded that in women with a multiple pregnancy, a pessary does not reduce poor perinatal outcome or preterm birth rates. However, in women with a multiple pregnancy and a cervical length below 38 millimeter, the Pessaries reduced both poor perinatal outcomes and preterm birth rates. I would like to thank many people, all the women that participated in the study and all the people that worked with the Dutch Obstetric Consortium, and a special thank you to Ben Mol and Dick Bekeram. Thank you for your attention.
Good morning. It's my pleasure to introduce our next presentation, multiple courses of antenatal corticosteroids for the preterm birth study, or the 5-year outcomes, or MAC5, and that's to be presented by Dr. Elizabeth Asztalos.
Good. Good morning. I'd like to thank the Society for inviting us to present the results of the MAX5 study. We know that between 7 to 12% of all pregnancies end in preterm delivery, and it's a major cause of infant mortality and morbidity. It is also responsible for millions of healthcare dollars. Antenatal corticosteroid therapy is a rare example of a treatment that yields both a cost savings and an improved health outcome. I would like to bring you up to date with where we are at and how we got here. MAX is a randomized multi-center international double-masked trial of single versus multiple courses of antenatal steroids that were given to women every 14 days if they remained at high risk of preterm birth, and the results were published in The Lancet in 2008. Our primary question for that phase of the trial was whether or not multiple courses were effective in reducing the risk of perinatal or neonatal morbidity or significant neonatal morbidity. These were our primary outcome components, and this was the maneuver that was used in the trial. Women received repeated courses of steroids or a placebo every 14 days until they reached 33 completed weeks or delivery, whichever came first. This was the primary outcome of MAX, and as you can see, we found no difference between the two groups. We also were very concerned at that time that there was a significant difference between the birth measurements of the infants between the two groups, and they were highly significant. At that point, we felt that this approach in therapy was not associated with neonatal benefits, but they were highly associated with a significant decrease in birth weight, birth length, and head circumference. We went on to see these children at 18 to 24 months again to determine whether or not this approach in steroids increased or decreased the risk of neurological impairment, the children at 18 to 24 months corrected age. And the results of this was published in Pediatrics in 2010. As you can see here, we again found no difference between the two groups. The incidence of the composite primary outcome was 13.8 compared to 13.7 in the placebo group, with an odds ratio of 1.001. When we broke it down to look at the individual components, again, there was no significant difference. However, we were able to show that there was catch-up growth with the children, although the children in the ACS group remained slightly lighter in weight, but again, not significantly different. At that point in time, we felt that this again did not increase or decrease the risk of death or neurological impairment compared to a single course. Although the children were still lighter in weight, the children did demonstrate catch-up growth. But there was a need to continue to follow these children and to determine whether there were subtle effects of steroid exposure that only becomes evident in later years. Hence the 5-year follow-up. Our question was, what is the effect of repeat courses of antenatal corticosteroids in the form that was given in MAX on the risk of death or severe disability in neuromotor, neurosensory, or neurocognitive function in the children by 5 years of age? Our primary outcome, again, was a composite of all death up to and including 5 years and survival with a severe disability in at least one of the following domains: neuromotor, a non-ambulatory cerebral palsy as defined by the GMFCS 3, 4, or 5, neurosensory disability, and neurocognitive disability. We also again took measures of growth with weight, height, and head circumference, and we were able as well to include blood pressure at this time. In addition, what we did is we did an extended follow-up with a small subgroup where we looked at intelligence and specific cognitive skills, be that visual motor, visual spatial, and language skills, as they were defined in the following three neurocognitive assessments, the WIPC-3, the Beery, and the Peabody Picture Vocabulary Test. At 5 years of age, the following was completed on as many children as possible: determination of survival, and if the children survived, the determination of neuromotor status and neurosensory difficulties. We then as well took growth measurements, we took blood pressure measurements, and then we completed the measures of cognition. All children had their parents complete the two questionnaires, the CBCL 1.5 to 5 and the brief P. For the Canadian centers, which was the extended follow-up, the children also underwent 3 additional neurocognitive assessments as previously described. Our sample size. When MAX-5 was being designed, MAX was still recruiting, so we had not reached our full sample for the trial. We made an assumption that 55 to 70% of the mothers of MAX would be eligible to be followed to 5 years. Our number was 1045 to 1330. We actually got 1724. We assumed that 80% of the mothers would come from the 45 centers that agreed to participate in MAX-5. We actually got 52 centers. We had a target sample size of 1,200 children, which we knew would give us a 40% reduction if a true reduction existed. We got 1,728, 144% above target. And our target sample for the Canadian centers was 250, which was supposed to allow us to determine 7 intelligent quotient points, and we got 283. This was our analysis plan. As consistent with the trial, it was an intention to treat. We calculated odds ratio and 95% confidence limits. We did a logistic regression that also controlled for premature rupture of membranes, multiple birth, gestational age at randomization, and the same approach was applied to each of the domains of the primary outcome. This was our timeline, and we were able to complete the entire trial in the 6 years that we targeted. This is the profile of the study, and as you can see, we achieved 81% of the intended follow-up of the eligible mothers and children. The baseline maternal, pregnancy, and infant characteristics were similar between the two groups in both phases of the trial. The incidence of the primary outcome and the neonatal morbidities were similar between the two groups of infants who were included in the analysis at 5 years of age. The distribution of singleton and multiples were equal in the two groups. The distribution of male and female were similar between the two groups. The children were all seen at a median age of 5.2 years. And this is our primary outcome. As you can see, 24.9% in the multiple courses had the composite primary outcome compared to 24.6% in the placebo or the single arm, an odds ratio of 1.02 and a level of significance of 0.84. When we looked at the individual components of the primary outcome, we did not have any elements that were of significance. When we did the logistic regression, again, there was no difference between the two groups. However, when we broke down and looked at the individual components that contributed to the variables that contributed to the logistic regression, you can see that premature rupture of membranes and gestational age at which the mother was randomized were significant. The growth measurements between the two groups remained unchanged and were not significant, were similar. As well, blood pressure was the same between the two groups, and again, not significant. When we looked at the extended follow-up, we found that the two groups in the Canadian cohort, which was 283 children, were again similar and again not significant. In summary, the risk of death or severe disability in neuromotor, neurosensory, or neurocognitive function were similar between the two groups, 24.9% versus 24.6%. Multiple courses of antenatal corticosteroid given every 14 days does not increase, nor does it decrease the risk of death or neurodevelopmental difficulties by 5 years of age compared to a single course. Because we could not identify short-term neonatal or long-term neurodevelopmental benefits, we conclude that multiple courses of antenatal corticosteroids, especially if it's given every 14 days, are not recommended for the woman at risk for preterm birth. We emphasize the continued follow-up of this cohort is needed to rule out the possibility of long-term neurobehavioral and neurosensory function, as well as disabilities, and metabolic and cardiovascular disease that could not be detected at this early age. Additional analyses will be conducted that will try to evaluate the interaction between multiple courses and outcomes as it relates to the prolonged rupture of membranes, term versus preterm birth, and infant sex as determined by animal studies. I would like to thank the Canadian Institute for Health Research for their generosity in funding this project and for the wisdom of allowing us to do this. It is also important to thank the entire MAX collaborative group, because without them this study could not be taken, and you can see that this is a huge group. As well, we must thank the family and the children who came back and continued with us to evaluate them at 5 years of age. Thank you.
Let's open up for questions.
Hi, Tom Garidi, Colorado. Thank you for that presentation. I'm most interested in the results. As I recall from Dr. Wapner's study of long-term follow-up, he did notice a difference in developmental disability after 3 or 4 courses of antenatal steroids. So I'm wondering whether you have a sub-analysis of outcome by number of courses.
We have not specifically have done that from the neurocognitive perspective. That is something that we will start to look at, yes.
Hello, Fionnuala McAuliffe from Dublin.
Where are you? Oh, there you are.
I'm over here. Congratulations on a great paper, and it's really fantastic to see long-term follow-up and in such detail. And I'd like to congratulate you on your great follow-up data, and I wonder whether you might share with us some of the strategies you employed to get such a high rate, 80% follow-up.
It was a lot of hard work. But I think that I have to give the congratulations to the sites themselves, because I was very fortunate that I had great collaboration with all the sites. We engaged not only the obstetricians but the neonatologists as well as pediatricians, who were able to work together in order to bring the families back. And I think that the families as well need to be congratulated, because we had many families that in fact called the sites and said, are you going to see us again? Are you going to come back? And we in fact were able to find children who were not included in the primary phase of the trial or even the 18 to 24 month, and they came back. So again, I think it's really a credit to the sites themselves that participated in this trial.
Thank you.
Hey, Mike?
Michael Ross, UCLA. Very, very nice work. And it appears that the measures you looked at this young age are fairly significant impacts. And yet in human studies, there's some suggestion of behavioral abnormalities induced by multiple course steroids, including anxiety, stress responses, and clearly in animal studies, particularly those done in Australia, of a programming of the offspring HPA axis that's in a sex-specific manner. Do you plan to look at any of those factors in the future?
We do. We, in fact, are hoping that the Canadian government will allow us to continue to follow these children to 12, and we will definitely engage in these measures. With respect to what we found now, the incidence of the findings, in fact, is a little higher than what is seen in the general population. So I don't know whether some of this is already a manifestation of what has been described in the animal studies, and we're just not seeing the difference. It's very, very hard to say. So the only thing we can do is continue to follow them to see whether or not it starts to separate itself.
Okay, thank you.
No.
Thank you. I would like to thank very much, and we are very proud on behalf of the group to present our work today. I would like also to thank the March of Dimes Foundation for the award. We know that twins remain at high risk of preterm birth. In 2010, in France, preterm delivery before 37 weeks represented 44% for twin pregnancies, which represented an odds ratio of 9. In USA, preterm birth before 32 weeks for twins was 11%, and the risk was 7 times greater compared to singletons. We also know that transvaginal sonographic cervical measurement between 20 to 24 weeks gestation might be a good predictor of spontaneous preterm birth in asymptomatic women with twin pregnancies. Even if the sensibility and specificity are low, we have interesting positive and negative likelihood ratios. We also know that progesterone plays a major role in the maintenance of the pregnancy. Several randomized trials in singleton pregnancies at high risk of preterm delivery have shown that prenatal progesterone administration significantly reduces the preterm delivery rate. This is why progesterone has been proposed for twin pregnancies. There are some studies, 8 studies, 7 of them were very recent, and any of these studies were unable to demonstrate that prophylactic progesterone could reduce the rate of preterm birth in twin pregnancies. And from the results of these studies, we extract 2 remaining questions. First, what is the efficacy of progesterone in twin pregnancies with a short cervix? And second, what is the efficacy of progesterone using higher doses? We hypothesize that the use of 70 progesterone could reduce the risk of preterm delivery in women with a twin pregnancy and a short cervix. To test this hypothesis, we performed an open-label multicenter randomized control trial in 10 university hospitals in France. Included women were older than 18 years, carrying twins and asymptomatic, had a short cervix, and were between 24 and 31 completed weeks of gestation. Ineligible women may add a cervical dilatation more than 3 centimeters, premature rupture of membrane, chorioamnionitis, monoamniotic twins, signs of twin-to-twin transfusion syndrome, severe IUGR, any fetal abnormality, death of 1 fetus, maternal or fetal disease requiring preterm delivery, or progesterone therapy before inclusion. Women were randomized when they have a twin pregnancy and a short cervix, using a computer-generated randomization sequence. In the first group, they received 500 milligrams of intramuscular progesterone repeated twice a week until 36 weeks or preterm delivery. And in the control group, the women did not receive any treatment because our ethical committee did not allow for a placebo injection. A previous study from Vessières, another French group, showed that the twin pregnancy with a short cervix had a mean time to delivery of 33 days with a standard deviation of 25 days. To demonstrate a prolongation of 14 days, we calculate that the necessary number of patients should be 160, 80 patients in each group. Our primary outcome was the time from randomization to delivery. Our secondary outcomes were rates of preterm delivery before 37, 34, and 32 weeks, and also the number of readmissions for preterm labor. The neonatal criteria included birth weight, transfer to NICU, transient respiratory distress, bronchopulmonary dysplasia, necrotizing enterocolitis, periventricular glaucomalacia, and death. We also recorded safety criteria as any severe maternal or neonatal adverse effect. We included 82 patients in the progesterone group and 83 patients in the control group. As you can see, the gestational age at randomization was 27 weeks in each group. And we have cervical length at admission of 15 in the progesterone group and 17 in the control group. This picture represents the distribution of time to delivery. We have in the x-axis the number of days from randomization, and in the y-axis the probability of delivery. And as you can see, the two curves are not statistically different. The time to delivery was similar between the two groups, 45 days in the progesterone group, 52 in the control group. The rate of delivery before 37 weeks was really high, 80% and 70%, and this confirmed that patients with a short cervix and twin pregnancy are at very high risk to preterm delivery. Surprisingly, we found that the rate of delivery before 44 and 32 weeks was increased in the progesterone group. This explains probably the gestational age at delivery reduced in the progesterone group, 34 weeks plus 6 days and 35 plus 3 days in the non-progesterone group. And the rate of vaginal delivery was similar and the other pregnancy outcomes as well. The neonatal outcomes were similar, were not different between the two groups, except for the birth weight of the second twins, which was 2,090 grams compared to 2,230 grams in the control group. And there was no difference in the other adverse neonatal outcomes. To summarize, we can say that the treatment with progesterone in twin pregnancies with a short cervix did not prolong pregnancy, but significantly increased in our study the rate of preterm delivery before 34 weeks, with no significant differences in neonatal morbidity between the 17 progesterone group and the control group. In conclusion, preterm delivery in twin pregnancies is probably due to uterine distension and contraction with no effect of progesterone prevention. We could say that the clinical implication of our study is that 17 progesterone is not effective in women with an asymptomatic twin pregnancy and a short cervix for prevention of preterm delivery, and it may even be harmful. I would like to thank all the people who participated to the groupe de recherche en obstétrique et gynécologie, especially Patrick Rosenberg, who is here today, and Marie-Victoire Sena, who is the first author and could not come today. And thank you for all the women with twins.
Thank you, Dr. Deruelle. This presentation is open for discussion. We start on my right there. Dr. Simhan.
Thanks for that presentation. Hi, Simhan, Pittsburgh. Were you able to obtain concentration of the 17P after initiating therapy to see if there's a concentration effect on length of gestation? And my second question is, in your population of screened women, what was the 25th percentile of cervical length?
We did not measure the concentration of 70 progesterone in the blood, but that's a very good question. I know there is an upcoming paper about the concentration of progesterone in the next American journal. I don't know the level of the 25th percentile in our study. I'm sorry.
Thank you.
Dr. Sibai.
Thank you for this presentation. You know, I feel good that I'm not the only one who has an accent here in the audience, you know. My question to you is that, what's the biologic plausibility for progesterone increasing preterm birth? One of the things I saw in your slide, you had more than 11-12% who received cerclage. When was the cerclage? Was it done before randomization or after randomization? The other question is, you had a large number of women who received acute tocolysis and maintenance tocolysis. How did this really play into all of this?
That's a very good question. I have different answers for the first question. It's clear that we had a slightly increase in the number of patients with a history of preterm birth in the progesterone group, but we can also say that there are some information about the role that could play castor oil in inducing contraction. And there is this very interesting study from O'Sullivan that showed that the contractibility of strips, myometrial strips, was increased with castor oil compared to no fluid in the in vitro concentration. And for the, I don't remember, your second question was?
Before randomization or after?
This is a pragmatic study, so we did not exclude patients who had a cerclage before randomization, and all the patients had their cerclage before the randomization.
How about tocolysis?
Tocolysis. We use tocolysis if necessary, but we have some kind of small problem in France that the people continue to use maintenance tocolysis even if it's not proved to be necessary.
Dr. Berghella.
Vincenzo Berghella, Jefferson, Philadelphia. First of all, Philippe, congratulations to you and Patrick for a wonderful work that you keep on doing, advancing science. My issue is, you gave progesterone 24 weeks and after, and I wonder if you have a sub-analysis, seeing if, maybe if you gave it earlier, you had a different effect, and if you give it later, if you saw more of the arm, later rather than earlier, or if you looked at the data that way. And, the message here is also that, we shouldn't use an intervention before it's been proven to work. And, I thank you for reminding all of us that scope creep should not be done. We shouldn't use an intervention before it's proven to work. Thank you.
Thank you. Thank you for the question. I don't think we have a sub-analysis comparing different time of injection. No, we don't.
Question here.
Benny Adeniji from Madeira. Dr. Deruelle, really congratulate you on this excellent study. We all have to remember caproate is not a natural product. I'm not sure how we came about the relatively higher doses that you used here, 500 and twice a week. Partly to answer some of Dr. Sibai's question, if you remember the earlier studies in rat pups using caproate, it did increase the rate of demise of some of those pups, and there's a chance that it increases apoptosis. So it may not be surprising that we actually had a worse outcome in the caproate group. And as we kind of go forward and look at the original Rouse study, where the number of women with recurrent preterm deliveries was actually higher, twice higher, 42 versus 17 in the control group, we really have to look at perhaps other progesterone sources. But I think caproate specifically, we really have to be very cautious about. How did we choose the 500 and twice a week dosing?
It's because we assume that a higher dose might be more powerful than the dose previously published. So we wanted to try the 500 milligram twice a week to see if it might be interesting. But after our study, I would not recommend to use this higher dose.
Thank you, Dr. Philippe.
Final question, Dr. O'Brien.
Yes, so Brian, Kentucky, echoing the same sentiments of the last two questioners, you repeatedly referred to your intervention as progesterone. And I wanted to know whether your group considers this progesterone or 17-hydroxyprogesterone caproate, and that the two may have very different pharmacodynamics, pharmacokinetics, etc., that may drive potential differences between those two particular interventions, because I think you can see similar graphs that you show now for 17-hydroxyprogesterone caproate.
Thank you.
Then our next presentation is entitled Antenatal Origins of Metabolic Syndrome in Fetuses of Obese Women, and will be presented by Andrea Edlow.
Thank you, Drs. Menard, Liu, and Sadi, and thank you to the Society for allowing us to present our work here today. 1 in 3 women in the United States is now obese at the time of conception, and the rise in maternal obesity has been paralleled by a rise in childhood obesity and metabolic syndrome, with 1 in 3 U.S. children now being obese or overweight, and 1 in 10 having metabolic syndrome. We know that children born to obese mothers are themselves at increased risk for childhood obesity and metabolic syndrome. And both the in utero exposure to maternal obesity, in addition to postnatal environmental influences, are contributing to the increased cardiometabolic risk noted in offspring. Maternal obesity perpetuates a transgenerational cycle, and all racial and ethnic groups are affected. Data from animal and humans demonstrates that maternal obesity leads to a metabolic syndrome-like picture in offspring, but the harmful effects may be occurring even during fetal life. In this hypothetical schematic, you can see that maternal obesity, and in fact pregnancy itself, are associated with increased inflammation and cytokine release, as well as insulin resistance. Increased adipose tissue lipolysis, in conjunction with the placental enzyme lipoprotein lipase, may result in increased transfer of lipid to the fetal compartment early in gestation. This in turn may reprogram multiple fetal organs, giving an increased risk for childhood metabolic disease and fatty liver disease. However, the underlying molecular mechanisms that are predisposing these children to increased cardiometabolic risk still remain largely uncharacterized. To our knowledge, there have been no studies performing global gene expression profiling in fetuses of obese women compared to lean in the second trimester. Prior work from our lab has demonstrated that second trimester amniotic fluid is a valuable source of real-time gene expression data in human pregnancies. Amniotic fluid supernatant is known to contain cell-free fetal RNA transcripts that reflect the development of several organs, including the brain, liver, pancreas, and thyroid. We therefore sought to perform a functional transcriptomic analysis of amniotic fluid cell-free fetal RNA in obese compared to lean women in the second trimester. We wanted to determine which genes are differentially expressed in fetuses of obese women in order to elucidate the possible molecular mechanisms underlying the increased risk of cardiometabolic disease noted in offspring. This was a prospective study including women undergoing second trimester genetic amniocentesis for standard clinical indications. We included 8 obese women with a BMI greater than or equal to 30 and 8 lean controls with a BMI less than 25. All fetuses were singletons and had normal karyotype on amniocentesis. We excluded fetuses with structural anomalies and matched obese cases with lean controls for gestational age and fetal sex, both of which have been demonstrated to influence gene expression. mRNA was extracted from amniotic fluid supernatant, converted to cDNA and amplified using commercially available kits, fragmented, labeled with biotin, and hybridized to Affymetrix whole genome arrays for gene expression analysis. Differentially regulated genes in fetuses of obese women were identified using the dependent t-test with a Benjamini-Hochberg correction to limit the false discovery rate, given the multiple comparisons being made. To give you a sense at how we arrived at our final gene list that was ultimately uploaded for functional analysis, the Affymetrix array that we used contains more than 54,000 oligos, interrogating more than 38,500 genes. We consider genes to be significantly dysregulated in fetuses of obese women if they were either up or downregulated in 8 out of 8 pairs and associated with a corrected p-value of less than 0.05. These genes comprise the final list that were uploaded to Ingenuity Pathway Analysis, or IPA, for functional transcriptomic analysis. IPA is a bioinformatics database that identifies biological processes, molecular and cellular functions, and signaling pathways that are dysregulated for a given data set. This is a systems biology approach and is much more powerful than a traditional gene-by-gene approach for discovery-driven experiments such as this one. We use standard significance cutoffs for microarray work, and in the upstream regulator portion of the IPA analysis, a z-score greater than 2 predicts the significant activation of a particular transcriptional regulator, while z-scores less than -2 predict significant inhibition. Looking at our demographics table, you can see that the study populations did not vary significantly with respect to any of the demographic variables apart from maternal BMI. Our results section will be divided into a portion about the specific genes that were significantly up or down regulated in fetuses of obese women compared to lean, and a portion about the functional analysis that we performed using ingenuity pathways. We identified 205 differentially regulated genes in fetuses of obese women compared to lean. 114 of these were significantly upregulated, while 91 were significantly downregulated. The most upregulated gene in fetuses of obese women was apolipoprotein D, or ApoD. The upstream regulator portion of IPA analysis predicted the significant activation of 3 transcriptional regulators in fetuses of obese women: estrogen receptor, STAT3, also called acute phase response factor, and CFOS or FOS. Turning first to the most upregulated gene in fetuses of obese women compared to lean, apolipoprotein D is a widely expressed gene that plays a critical role in cholesterol homeostasis and lipid metabolism. We know that increased exposure to cholesterol increases the production of ApoD, probably to maintain some type of homeostasis. Overexpression of ApoD in transgenic mice led to a metabolic syndrome-like picture. And interestingly, we know that ApoD is widely expressed in the central nervous system, with increased expression noted during human brain development and maturation. Turning now to the upstream regulator portion of the IPA analysis, the upstream regulator analysis can predict the activation or inhibition of transcriptional regulators that are upstream from the genes in our data set. Genes that are significantly upregulated are depicted here in red, while downregulated genes are depicted in green. You can see that because genes 1, 2, and 3 are significantly upregulated and genes 4 and 5 are significantly downregulated, IPA would be able to predict that this upstream regulator is significantly activated. You can conceptualize the predictive modeling used by the ingenuity pathway analysis if you think about decision science, which is something that's utilized by all of our computers every day to infer our preferences. For example, if you were to buy the Michael Jackson CD Bad on your computer, and then later search YouTube for videos on how to perform the dance from Thriller, the next time that you log into Amazon.com, your computer might predict or infer that you would want to buy this jacket. Not that this has ever happened to me. Looking now at the z-scores that IPA assigned to putative transcriptional regulators based on the direction of gene expression in our data set, you can see that the only transcriptional regulators that achieved statistical significance were estrogen receptor, CFOS, and STAT3. All of these were associated with z-scores greater than 2, predicting their significant activation. Turning to the first upstream regulator that was significantly activated in fetuses of obese women, estrogen can signal via the classical pathway, where it enters the cell, dimerizes, and translocates to the nucleus to directly control gene expression, or can act via a non-classical pathway, binding to cell surface receptors, and then stimulating kinases and intermediate transcriptional factors to thus influence gene expression indirectly. Why do we care if estrogen signaling is upregulated in fetuses of obese women? We know from our experience with DES, a synthetic estrogen, and more recently with bisphenol A, or BPA, an estrogenic compound that is widely present in many household items, that excess estrogen signaling in utero can have harmful effects, including the early onset of puberty in girls and an increased risk for obesity, breast, and other reproductive tract cancers in offspring. The second upstream regulator predicted to be significantly activated in fetuses of obese women is STAT3, also called acute phase response factor. STAT3 is activated by the binding of cytokines to the cell membrane. and activated STAT3 heterodimers then translocate to the nucleus to control gene expression and cell cycle progression. STAT3 has been implicated in glucose homeostasis and growth hormone signaling, but also in pathologic processes, including hyperleptinemia and hepatic steatosis. STAT3 is known to upregulate BCL2, an anti-apoptotic gene, and I'll discuss in greater detail the role for decreased apoptosis in fetuses of obese women tomorrow in abstract number 37. The final upstream regulator that was predicted to be significantly activated in fetuses of obese women is FOS, or CFOS. This is a proto-oncogene that dimerizes with other transcriptional regulators in the nucleus to influence gene expression. You can see that it's activated by a variety of inflammatory mediators, including lipopolysaccharide, interferon gamma, and other cytokines, and viruses. We also know that CFOS expression is increased by leptin, and CFOS has therefore been implicated in appetite regulation. Significant crosstalk exists between CFOS and STAT3, one of the other transcriptional regulators significantly activated in fetuses of obese women. CFOS has also been implicated in a variety of inflammatory conditions, including atherosclerosis, coronary artery disease, and is an important regulator of cell proliferation and apoptotic cell death. In conclusion, our analysis of cell-free fetal RNA in the amniotic fluid of obese women demonstrates differences in gene expression as early as the second trimester. These differences included significantly increased expression of ApoD and significant activation of estrogen receptor, STAT3, and CFOS. Taken together, these findings suggest a pro-estrogenic, pro-inflammatory milieu for fetuses of obese women. The molecular mechanisms predisposing offspring of obese women to cardiometabolic complications may therefore be initiated as early as the second trimester. We hope that given the epidemic of maternal obesity in our country, that this preliminary work in a small group of women will form the foundation for future investigations and hopefully interventions. I have many people to acknowledge. I've been fortunate to have so many outstanding mentors at Tufts, especially Diana Bianchi, the PI for this project. Thank you so much. And also to Dr. Sabrina Crago and Dr. Errol Norwitz of the Division of Maternal Fetal Medicine at Tufts for your mentorship. Everyone in the Bianchi Lab and at the Mother Infant Research Institute where this research was conducted, in my division at Tufts, and also the NICHD for the funding to conduct this research. Thank you. I'm happy to take any questions.
This paper is over for questions. Let's begin here.
Rodas, Hartford, Connecticut. Great work. Thank you so much. So the question is it obesity or is it what they're ingesting while they're pregnant? Do you have any data at all on the nutritional status of the two patients during, or the two groups during the pregnancy?
Thank you for your question. That's a very good point. We did not collect data on the nutritional status of the women during pregnancy. There have been animal models that have looked at mice ingesting a high-fat diet during pregnancy, but there have actually not been models that we're aware of where they looked at obese mice before pregnancy, feeding them a high-fat diet, or feeding them a normal diet in pregnancy. And so we actually hope to do that with a mouse model that we recently got funding for.
Let's go to the central.
Elisabeth Schepers, the Netherlands. Do you have any data on the gene expression of the mothers?
Thank you. That's an excellent question. We don't have data on the gene expression of the mothers, unfortunately, but that would be an important direction for future work.
Out here to the right, please. My right. Yes,
Ross,
Mike, I couldn't see you.
Thanks. Ross, UCLA, very nice work. Obviously, lots of questions as to which organ is producing this RNA and clearance into amniotic fluid, clearance out. But I guess that the most pertinent question I would ask is, do you have any samples of cord blood in these infants? Is there a correlation between the amniotic fluid and the cord blood, because it would be the cord blood that could potentially serve as markers of future metabolic syndrome in these offspring?
Thank you so much, Dr. Ross, for your question, and we've read your work with great interest. So we don't have cord blood from these particular fetuses, But we actually did do a separate study that we're working on right now where we collected both cord blood and amniotic fluid at term from fetuses of obese women who had no other complications of pregnancy. And that microarray work has been done, but the analysis is undergoing. So I hope to be able to tell you the answer later.
Great. We'll look forward to it.
Thank you. Let's go to the center again, please.
I'm Asztalos from Pittsburgh. The data are very interesting. I wonder if you know anything about the fate of those mRNAs. Obviously, you cannot do this in women, but has anybody done such studies in any animal model where you can label the mRNAs and really identify where they may go and affect protein expression?
Thank you. That's a very good question. I'm not aware of any ability to label mRNAs or follow mRNA trafficking in the amniotic fluid in animals or humans, but there is some initial work on labeling that's being done. I think certainly it would be tested first in animals, but to my knowledge, there isn't yet that technology available, but it would be important.
It's available. I think your study suggests it probably should be done in a mouse model.
Yes, that's one of the next steps that we're going to try to work on when we get back.
We have time for one more question here on my left, please.
Bernie Gonick from Detroit. Can you tell us how you know this is fetal mRNA?
That's a very good question. Initial work by Lisa Hoy in our lab characterized an amniotic fluid transcriptome in fetuses of normal weight or normal women without complicated pregnancy, and that work was published in the Green Journal in 2012. So to the best of our ability to tell, using available bioinformatics resources that are publicly available, we looked at a gene atlas that examined tissues from humans and fetuses and made a list of mRNAs that mapped highly to certain tissues exclusively. And then Lisa was able to characterize genes that were present in all fetuses in 12 women and looked at only the mRNA transcripts that mapped specifically and highly to organs in this gene atlas. And that's how we're inferring that these mRNAs map to fetal organs. And work in women, for example, cell-free fetal DNA in maternal blood comes from the placenta. But to the best of our ability to tell, the amniotic fluid is a biofluid that mostly reflects the fetus. So that's why we feel that the mRNAs are coming from the fetus. And that work has been demonstrated in blood as well.
Thank you very much.
Action be part of the active management of third stage of labor. So the tri-cohort multi-center randomized control trial to be presented by Dr. Deneux-Tharaux.
Yeah, this is good. Thanks to the organizers to have given us the opportunity to present this work to you today. Postpartum hemorrhage remains a major complication of childbirth. In high-resource countries, severe PPH complicates about 1% of deliveries, making it the main component of severe maternal morbidity. Thus, prevention of PPH constitutes a crucial issue and is recommended in all women, given that individual risk factors are poor predictors. Active management of third stage of labor has been proposed for the prevention of postpartum hemorrhage. In its standard definition, this package combines 3 procedures: administration of a uterotonic drug just after birth, early cord clamping and cutting, and control cord traction. This package has been associated in several trials with a 60% reduction in the incidence of postpartum hemorrhage. Given this efficacy, it has been included in national and international recommendations for PPH prevention. However, the specific effects of each of its components have not been adequately evaluated. The independent efficacy of preventive oxytocin has been demonstrated with a good level of evidence, but this was not the case for control cord traction. So what is control cord traction? It consists in pulling the cord, starting immediately after birth with the first uterine contraction without waiting for placenta separation, and this is the main point of this technique. This is a bimanual technique with one hand pulling the cord downwards, while the other hand is exerting a counter pressure on the uterus upwards. Although most recommendations of PPH prevention include control cord traction, its actual integration into practice remains highly variable. This graph shows policies of maternity units in 14 European countries, and you can see a real contrast between, in pink, the proportion of units in each country recommending prophylactic oxytocin, which is more than 80% of the units in most countries, contrasting with, in blue, the proportion of units recommending control cord traction, which was less than 50% in most countries except the UK and Ireland, these two countries being those countries where active management was initially promoted. And in some countries, control cord traction, or at least in some units in some countries, control cord traction was even considered poor practice and even forbidden and taught as such in midwifery schools because of the potential risk of uterine inversion. And this was the case in France. This variation in use of control cord traction may be explained by the paucity of the available evidence for assessing either its efficacy or its risks. Indeed, until recently, only 2 small trials conducted in the 60s were available, but they had many methodological limitations, and they provided contradictory results. A few months ago were published the results of a WHO trial, a large randomized control trials conducted in 8 low and middle income countries, comparing active management of the third stage with or without control cord traction, and they found no difference in the incidence of severe PPH. The authors concluded that control cord traction could be omitted in non-hospital settings, and that was a major point in this kind of countries where a large part of deliveries actually occur in non-hospital settings. However, the external validity of these results is questionable. In this context, our objective in the TRACOL trial was to assess the impact of control cord traction on the incidence of postpartum hemorrhage and also on other characteristics of the third stage of labor in a high-resource setting. This trial was conducted in 5 French university hospitals, none of them using control cord traction before the trial. Women were randomly assigned to have their third stage managed either by control cord traction or by standard placenta expulsion, and that was the standard way of managing this phase in France, which consists in waiting for signs of spontaneous placenta separation before having the placenta delivered through maternal efforts, sometimes helped by fundal pressure if needed. For all other aspects of the management of third stage, the women were managed in the 2 groups similarly, and in particular, all women received 5 units of oxytocin just after birth. Our primary outcome was the incidence of postpartum hemorrhage defined as a measured blood loss of at least 500 millimeters. To be able to show a 30% decrease in the incidence of postpartum hemorrhage in the control cord traction arm, more than 4,000 women were needed. And actually, we managed to include this number in the expected time schedule. Here is our primary outcome results, and you see that the incidence of postpartum hemorrhage was about 10% in each group, with no significant difference between the 2 groups. The results were similar for other secondary outcomes characterizing postpartum blood loss, no difference in the incidence of severe postpartum hemorrhage defined by blood loss of 1 liter or more, 1.7% in the control cord traction arm and 1.8% in the standard placenta expulsion arm, no significant difference in the total blood loss, and all women had a blood count at day 2 postpartum, and we were able to calculate for each woman the peripartum drop in hemoglobin and in hematocrit, and there were also no significant difference in these biological markers of postpartum blood loss. So in conclusion, no difference in any of the outcome related to postpartum blood loss. However, we found some differences between the two groups for other aspects of the third stage. As could have been expected, the duration of the third stage was shorter in the control contraction arm, and this difference was statistically significant. The proportion of women having a third stage lasting more than 15 minutes was significantly different in the control contraction arm, with a 70% reduction. The need for manual removal of placenta was also decreased in the control contraction arm with a significant 30% reduction. And there were also less women having pain during the third stage, and this was also statistically significant. Cord rupture occurred in 4% of women in the control contraction arm, and no uterine inversion occurred in this trial. In conclusion, control contraction does not decrease the incidence of postpartum hemorrhage, so there is no evidence to recommend routine control contraction for the prevention of postpartum hemorrhage. However, this intervention reduces the duration of the third stage and the need for manual removal of placenta, and these effects might have potential benefits in terms of organization of care in labor ward, infectious risk, and women's experience of this stage. Finally, we found that this procedure is safe when performed by trained clinicians, and this is an important result, especially for those settings where it was considered at risk. These results have implications for clinical practice. They show that the administration of oxytocin is the main intervention for PPH prevention at birth, and regarding control contraction, in units where this intervention is routinely performed, clinicians should know that it can be omitted with no increased risk of postpartum hemorrhage, and it should not be a barrier to implement a policy of delayed cord clamping, and you know that there is an increasing amount of evidence showing potential benefits for the baby of such policy of delayed cord clamping. In units where control contraction is not performed, clinicians may consider introducing it into their practice if the secondary benefits we've showed in terms of duration of third stage and less need for manual removal of placenta appear as important issues in their local context. Thanks for your attention.
Okay, let's open it up for questions.
I'll start with one as the people come to the microphone. That I was impressed that you know the protocols on the maternity wards throughout the country. There's so many countries that you appeared on this slide. We don't know that in the U.S., and we have so much to learn from our international colleagues. My question is, how in the study did you measure blood loss?
It was all women had a collector bag set up just after birth, a plastic collector bag, graduated bag, you use that. And so blood loss was measured in the bag. So the bag had to be left in place at least for 15 minutes for all women, and then it was removed when the midwife considered it was no longer necessary.
We'll go to the note.
Hello, Tony Armstrong from Halifax. Thank you for looking at this intervention in such a robust way. An excellent study in terms of the sample size, etc. My question relates to cord rupture, and I noticed that it was 4% in the intervention arm. That certainly isn't trivial, and that is one of the things that I think prevents many of us for using that technique. And I'm surprised that the frequency of retained placenta and requirement for manual removal was less in the intervention group when you had 4% cord rupture rate.
Yeah, thanks for this question. Actually, less than half of the cord rupture led to manual removal of placenta. So in half of the cases, the placenta could be delivered through maternal efforts, even when the cord had ruptured.
Go to the far side.
Lakshmi Bakshi from New York. A very interesting and a practical problem which you address. The question which I have is, Did you have a further follow-up on this patient? Because it has been observed that some of these patients may have a retained cotyledon. Now, your follow-up is immediate. What about the later follow-up? How many of them later on required either a DNC or prolonged bleeding for a long time in either group?
We followed the woman until they left the hospital after the postpartum stay, and there was no increase in postpartum complications, but we did not plan to follow the woman after the hospitalization.
Well, I'll ask a question. Did you conduct subgroup analyses to see which group of women might actually benefit more from cord retraction? For example, are there obese women or women with protracted second stage? Did you look at those subgroup analyses?
Yeah, we plan subgroup analysis in women in primiparous women, because they're known to be more at risk of PPH, and also in women with long first stage of labor, and we found no difference.
Thank you. Dr. Menard, Dr. Liu, members and guests, I would like to thank the Society for allowing me to present on behalf of the Eunice Kennedy Shriver National Institute of Child Health and Human Development Maternal-Fetal Medicine Units Research Network. Cervical length in the second trimester has been shown to be predictive of preterm birth, with likelihood ratios for a positive test between 6 and 12, depending on the cervical length cutoff used. When measuring the cervix by transvaginal ultrasound, other findings may be noted that also relate to the risk of preterm birth, such as funneling or intra-amniotic debris, sometimes referred to as sludge. The studies regarding these ultrasound findings found different degrees of association with preterm birth. Limitations of the prior studies included small sample size, retrospective design, and inclusion of heterogeneous risk groups, such as women with cerclage or prior preterm birth. Moreover, not all studies had standardized training, rigorous ascertainment of outcomes, or controlled for cervical length. Our objective in this analysis was to evaluate whether the presence of cervical funneling or intra-amniotic debris is associated with higher rates of preterm birth in asymptomatic nulliparous women with a short cervix. This is a secondary analysis of the NICHD MFMU network randomized trial of 17-hydroxyprogesterone caproate for prevention of preterm birth in nulliparous women with a short cervix, or what we refer to as a SCAN trial. In this trial, nulliparous women between 16 and 22 weeks with a singleton gestation and a cervical length less than 30 millimeters on transvaginal ultrasound were randomized to 17-OHPC or placebo. These women did not have other risks for preterm birth. Endovaginal ultrasound was performed between 16 and 22 weeks by trained and certified sonographers for cervical length measurement, as well as checking for cervical funneling and intra-amniotic debris. All sonographers were trained to follow the methods published by Iams and colleagues and were actually certified by Dr. Iams himself by central image review prior to the study. The primary outcome was preterm birth less than 37 weeks. Secondary outcomes were preterm birth less than 35, less than 34, and less than 32 weeks, as well as a composite of adverse perinatal outcomes listed here. Wilcoxon rank sum test was used to compare continuous variables, and chi-square or Fisher's exact test were used for categorical variables. Survival analysis with log rank test and logistic regression analysis to control for treatment, cervical length, and gestational age were also used. A p less than 0.05 was used to denote statistical significance. More than 15,000 nulliparous women were screened between 2007 and 2011. 1,588, or about 10%, had a cervical length less than 30 millimeters, and 657 were randomized to 17-hydroxyprogesterone or placebo. In the primary analysis, which has been published, the frequency of preterm birth did not differ between the 17-OHPC and placebo groups for any of the gestational age cutoffs. Of the 657 women randomized, 24% had funneling, 12% had debris, and 7% had both funneling and debris. In this table and the next, cases were women with funneling and or debris, and controls were women with neither funneling nor debris. Women with funneling and or debris were older, less likely to be non-Hispanic white, and had a higher pre-pregnancy BMI compared with women who had no funneling or debris. Insurance type, marital status, and substance use were not significantly different. Cases were also more likely to have had a prior pregnancy that did not reach 20 weeks, higher gestational age at screening, and shorter cervical length. On univariable analysis, preterm birth was significantly more common in women with funneling compared with women without funneling for all the gestational age cutoffs analyzed. Similarly, women with debris were more likely to deliver preterm than women without debris. The difference became progressively wider with decreasing gestational age cutoff, with 26% of women with debris delivering before 32 weeks compared with only 6.7% without debris. The risk of preterm birth in women with debris as well as in women with funneling remained elevated even after adjustment for treatment with 17P. Funneling, however, was no longer associated with preterm birth when adjusted for treatment and for cervical length, but preterm birth before 35 weeks remained significantly more common in women with debris. Ultrasound to delivery interval was also significantly shorter in women with debris, and this difference remained significant even after adjusting for treatment, cervical length, and gestational age at ultrasound. Now for the neonatal outcomes. Neonates born to mothers with debris had lower birth weight and were more likely to have 5-minute Apgar score below 7 and be admitted to the neonatal intensive care unit compared with women without debris. Their NICU stay was also longer compared with neonates born to women without debris. The composite outcome, as well as several of the individual adverse outcomes, were also more frequent in the debris group, with odds ratio reaching 15 in some of the cases. The association with adverse composite outcome remained after adjusting for treatment, but lost statistical significance after adding adjustment for cervical length in the middle. The point estimate and confidence interval moved further to the left after additional adjustment for gestational age at delivery, shown on the bottom. In conclusion, cervical funneling is not independently associated with preterm birth in nulliparous women with a short cervix. Intra-amniotic debris increases the risk of early preterm birth independently of the cervical length, and presence of debris is associated with worse perinatal outcome, mainly through its effect on preterm birth. I'd like to acknowledge all the centers that contributed to this study and to the more than 15,000 women who had an ultrasound in the second trimester, and mainly thank all the research coordinators at these centers. I would like to also thank Dr. Sharon Gilbert, who was the primary biostatistician for the trial, and the NICHD Pregnancy and Perinatology branch. Thank you for allowing me to present our work.
We welcome questions for Dr. Sadi. Over here on my left, please.
Yes, Jimmy Espinosa, Baylor College of Medicine. Congratulations on the results.
Thank you, Jim.
This is more a comment in regards of semantics. Debris probably implies a fragmented, non-viable tissue, but in cases in which you actually happen to obtain the samples, these represent essentially a cluster of pro-inflammatory cells, some bacteria, and sometimes this polymeric matrix that represents biofilms. So perhaps amniotic fluid sludge or particulate matter may be a more appropriate term instead of debris.
Thank you, Jimmy. I mean, I'm aware of your papers on that. They were called debris in the protocol and the manual of operation, and that's how the training was performed, and probably the name was stuck there before your publications. Thank you.
Dr. Greedy?
Thank you, George. That was really important and fascinating information. I'm curious if you have any data on infectious complications among patients with debris as compared to those without either chorioamnionitis or neonatal sepsis.
That's a great question and something we're looking at, and Dr. Gilbert is going to look at it right after we leave here, so thank you very much. What was really interesting, though, and maybe I should have highlighted it more, but the rate of growth restriction or severe growth restriction, which we consider as indicated preterm birth, was actually lower in the debris. So it must be something else with the debris that's causing these preterm births.
Thank you. Thank you very much. And I want to thank the Society most humbly for accepting our presentation. I remember when I came to my first SMFM meeting 20 years ago as a fellow and coming to a plenary session and looking up, and I thought, wow, that was the Holy Grail. So I've got 15 minutes and I'm going to enjoy it because it doesn't last for long. But I'm going to present to you a randomized controlled trial of planned vaginal birth or planned cesarean section versus planned vaginal birth for twins between 32 and 38 weeks, with the first twin presenting vertex. And really I'm presenting here as a representative of my steering committee, whose names are listed on the presentation, and really for the Twin Birth Collaborative Group. I'm not going to ask you all to stand up, but you're here, and without you all, the study could not have been done. Could also not have been done with the sponsorship and support of the Canadian Institute of Health Research, from Sunnybrook Hospital and the department who helped me with support, the University of Toronto, and that little emblem in the top right-hand corner, which is the Centre for Maternal and Infant Child Research, and I can't change the slide. Left hand, okay. So that's the team. That's the support team from the Centre for Maternal Infant Child Research. It takes a huge number of people to do a trial for that lasts 10 years. That involves 106 centres in 26 countries. I could not have done this without them. Two special people who need mention are Dayla Mason there immediately holding the number 2. She was the principal coordinator of the trial. And you've already heard from Liz Asztalos, who's the director of the unit, and that's the team which we did. So why did we do this trial? I'm a maternal fetal medicine specialist and specialize in twins. Surely I should be involved in premature birth and twin transfusion and laser and all that fancy stuff. Well, the problem is all these twins need delivering. And they're increasing incidence, and we were delivering them all, or many of them, by an increased use of cesarean section. The trend to cesarean section was increasing. And also, concomitant with this were decreasing number of clinicians with skills and experience in operative vaginal birth. Some of this was due to the term breech trial, which inhibited the delivery of breech babies, and that was extrapolated, I heard, in these very rooms, the questions, well, what about twins, now that we've answered the question in singletons? So with that background, there was also research. There was meta-analyses, which looked at the outcome of planned vaginal birth and planned cesarean section, which showed no difference in the outcome, which led many of us to continue doing planned vaginal birth. But then were very significant cohort studies which were well designed from important groups. Some of them was Tony Armson, who you heard in the audience, and which showed that for twin B, we always know that twin B is the one that is the one at risk, that twin B is at increased risk of death and morbidity compared to twin A. And that elective cesarean section may decrease this risk of adverse outcome of twin B compared to twin A. So for me as an obstetrician, I always regard myself as this sort of silly-looking guy on the right who's been trained to do twin deliveries, who's got the meta-analysis in his pocket saying, don't worry, it's safe. But on the other side, these cohort studies which he's weighing down and causing many of us, along with all other reasons to perform cesarean section, to rather than do planned vaginal birth, which is what many of us were trained for years, but to perhaps switch to planned cesarean section. So we were in a position of equipoise from a fetal perspective. So we developed the primary research question for twins between 32 and 38 weeks with the first twin presenting vertex. Does a policy of planned cesarean section decrease or increase the risk of perinatal or neonatal mortality or serious neonatal morbidity compared to a policy of planned vaginal birth? We did a randomized control trial with central computerized randomization at the Center for Maternal Infant Child Research. Everyone got informed consent. We stratified for parity, primips and more than one pregnancy, and we also stratified for gestational age at randomization in the blocks that you can see showing on the slide. Who did we include? We included all twins between 32 and 38 weeks gestation, the twins between 1,500 grams and 4,000 grams by ultrasound within 7 days of randomization. The first twin had to be presenting vertex, and obviously both twins had to be alive at randomization. Who did we exclude? We excluded twins in which everybody would probably agree would need cesarean section, monoamniotic twins, a lethal fetal abnormality, and a contraindication to labor or vaginal delivery of either twin. This was a slide I never quite understood, or a point previous participation in twin birth study. Each patient has a unique identifier, and when a trial takes 10 years, yes, there were some patients who came back twice and wanted to be in the trial, twins. Now, this is an important trial. It's a trial that you are judging somebody's skill and efficacy and expertise. You're also judging the center. So we had to have inclusion criteria for which centers we would be allowing to participate in a trial. They had to have antenatal ultrasound performed on the twins every 4 weeks. Experienced personnel had to be available and at delivery. They needed facilities for emergency cesarean section. And as Dr. Asztalos has shown to you in our unit, the ability for neonatal care and follow-up is important, because without that, we lose some of the power of answering many of the questions we have. Important as well is we needed to have obstetricians who were skilled and experienced in delivering twins if we wanted to answer the question as to what the best method of delivery is. And this is the criteria we used. We suggested that if somebody thinks themselves are skilled at twin delivery, that's a start. If a head of department If the head of department agrees that they're also skilled, well, that's a second method. And I think important is that we wanted these people who were delivering these babies to be qualified obstetricians in the participant countries. So obstetricians in training without the qualifications were only allowed to do that with a direct participation, supervision, and in next to the patient bedside of someone who was qualified with the other selection for the criteria. Without a randomized trial, and I think even now with a small randomized trial, we decided that the twin pregnancy should probably best be ended by between 37.5 weeks and 38 weeks gestation, and that happened either by elective cesarean section or by inducing labor, depending on the depending on the randomized group. I'm going to go through these primary outcomes in a little detail because we all must be happy that each one of these, because a composite outcome, right? Each one of these must be significant enough for you to decide that if any of these happened more commonly in the other group, you would have wished you have delivered the baby the other way. So I'm going to read them. Death before 28 days of life, perinatal and neonatal mortality, birth trauma, including subdural, intracerebral hemorrhage, spinal cord injury, basal or depressed skull fracture, long bone fracture, or peripheral nerve injury that was present at discharge. An APGAR score of less than 4 at 5 minutes. Abnormal level of consciousness of the babies, described as coma, stupor, or decreased response to pain. Seizures, within more than 2 seizures within 72 hours of birth, and then prolonged ventilation for more than 72 hours for more than within 72 hours for more than 24 hours. Septicemia, meningitis is proved by blood or CSF culture, necrotizing enterocolitis, BPD, and severe grades of intraventricular hemorrhage. Now, I'm glad you say we mustn't forget the mother, and many of our trials, I think, does this, and so we wanted to make sure that we looked at maternal outcomes. So I'm going to read the maternal outcomes that we looked at. Death, significant hemorrhage, blood loss more than 1,500 mils, giving a blood transfusion, the need for a DNC, the need for laparotomy, significant genital tract injury, hysterectomies, hematomas as confirmed by CT or MRI, intraoperative damage of significant organs, ureter, bowel, or third and fourth degree tears. Thromboembolism requiring anticoagulant therapy, systemic infection, pneumonia, or severe sepsis, wound infection that prolonged the pace of stay in the hospital or required readmission or led to dehiscence of the abdomen, and other major life-threatening illnesses such as adult respiratory distress syndrome, etc. Well, our sample size was thought to be about 4% based on the Attlee Nova Scotia database, a very robust database which collects almost all the outcomes in huge populations, and we thought we'd get about a primary outcome of 4%. And in order to show reduction from 4% to 2%, which most people would think of significance, we needed 2,800 women to show with an 80% power with an alpha two-sided error of 0.05. We did two interim analyses, the first after the first 1,000 patients, the first after 1,800 patients with more stringent, significant levels for stopping. It's obviously an intention to treat analysis. We used a method of statistical analysis to demonstrate that the outcome of each baby is dependent. Their P was less than 0.05 for primary outcomes and 0.01 for other outcomes. And yes, we did it. 2,804 women randomized. The first patient was recruited actually on my birthday on the 13th of December 2003 and finished in April 2001, 106 centers in 25 countries. 1,398 women were allocated to planned cesarean section and 1,408 to planned vaginal birth. And as you know now from the rest of the morning, you lose patients and you lose babies. 6 women were lost to follow-up initially, leaving and then 2 infants and 4 infants respectively in the 2 groups, leaving 2,781 infants contributing to the composite primary outcome in the planned cesarean group, and 2,782 infants contributed to the primary outcome, to the composite primary outcome in the planned vaginal birth group. There were 21 neonatal deaths or stillbirths in the planned cesarean group, and 17 neonatal deaths or stillbirth in the planned vaginal group. And this left 2,780 infants, which were available to contribute to the morbidity outcome in the planned cesarean group, and 2,765 infants, which contributed to the neonatal morbidity outcome in the planned vaginal birth group. 1 mother was lost to follow-up, leaving 1,392 women, which contributed to the analysis of the maternal outcome in the planned vaginal group versus the 1,392 women in the planned cesarean section group. So the baseline characteristics, like most of you know, when you do a randomized trial, there's no surprise. Well, you pray that there's no difference in baseline characteristics, and that's what we found, thankfully, that there's no difference in baseline characteristics. I just want to point out to you at the bottom of the slide that the majority of the women were recruited there between 32 weeks and 36 weeks. About 80% of the women were recruited in the category 32 to 36 weeks. Some more baseline characteristics, which is going to be interesting to the obstetrician. People are going to say, well, was the weights of the babies different? No, they weren't. What about your chronicity? Well, we included both in the suspected ratio. Most were not in labor at randomization. And the majority of our patients, I think very important, were recruited from countries with low or medium perinatal mortality rates, less than 15 per thousand and 15 to 20 per thousand. Which is the holy grail, the vaginal birth or the cesarean section. So I'm going to talk briefly about, to a group of obstetricians, the delivery characteristics. I think it's important to know that about 60%, or 56.2% of the twins both were delivered vaginally. And I think what's also really relevant is people would say, well, the reason I don't want to have a cesarean is because of my chance of having the worst of both worlds, vaginal of one and cesarean of the other. In this trial, it only happened in 4% of those women, so we think a fairly small percentage. The gestational age of delivery was significantly different between the 2 groups. Women in the planned cesarean group delivered significantly earlier than those in the planned vaginal group. And I think also important on the slides is to see that the majority of the women actually delivered between 34 and 38 weeks. Important for our trial in terms of the ability to follow protocol is that in more than 98% we were able to be assured that an experienced practitioner was available and delivered the babies at the time the patients were delivered. So this is the slide that we worked towards for 10 years. It's the slide and the data that I think will preserve the art and skill of operative vaginal delivery and will serve all of us as a warning lesson that before we trend to what is seemingly an easier and safer option of cesarean section, we should think twice. Because the primary outcome of perinatal, neonatal mortality or serious morbidity was not significant difference between the two groups. In the planned cesarean group, there were 57 events versus 52 in the planned vaginal group, the odds ratio of 1, and certainly not statistically significant. Just to show you some more details of the deaths were most commonly in both groups were before labor, and there was only one death during delivery, and it was in the vaginal birth, and the others were neonatal deaths occurring after birth. Here is the morbidity. I'm going to go through it. That you will know there is no difference in the incidence or the rate of serious neonatal morbidity, 36 versus 35. In the vaginal birth group, the birth traumas, certainly the long bone fractures seem to be more common in the vaginal birth. But note the intracerebral hemorrhage seems to be more common in the planned cesarean section. APGAR scores, not surprisingly, I thought, was vaginal birth had more of the APGAR scores, less than 4. But look at the level of consciousness difference, seems to be more common in the planned cesarean section. In terms of seizures, equally balanced, sepsis about equally balanced, neck, very small numbers. But interestingly, the cystic PVL, the forerunner of cerebral palsy in many cases, was more common, or there were more events in the planned cesarean section group. What about the mother? We mustn't forget the mother. There was no difference in maternal morbidity or serious maternal mortality or serious morbidity between the two groups, 102 events versus 118 events. Now, that should really be where the talk stops, because who knows what we find when we do secondary analyses, right? But I'm going to present a few of them because I think they're interesting to obstetrician. Is this finding true for all the other variables that you might think might interfere with the outcome? And yes, it is. That none of these variables had any effect on the treatment effect. Parity, mother's age, the presentation of twin B, no, it's not more dangerous for a twin to be breech or vertex. Chorionicity makes no difference. No, it's not more dangerous to be a monochorionic twin. And the perinatal mortality rate between countries, there was no effect on the primary outcome. Now, what we do know, and what is still true, is that it's bad to be a twin A. You have about a twin B. You have a significant 1.8 odds ratio, more higher risk of having the primary outcome. So it is more dangerous to be a twin B, and that's still true and proven by the trial. What is also true, though, is that cesarean section has no effect on that risk. In other words, the treatment did not have any effect on either twin A or twin B. An important slide, the gestational age of randomization. This slide shows that there's no significant interaction between the treatment group and the gestational age at randomization for the primary outcome. In other words, this indicates that the effect of treatment, planned cesarean versus planned vaginal birth, on the primary outcome does not differ between the gestational ages. However, you can see it is different. It is a different figure. And if that were true, it might indicate that cesarean section might have a reduced rate of the primary outcome in those patients who make their treatment plan only after 37 weeks. So in summary, planned cesarean section does not decrease or increase the risk of perinatal or neonatal death or serious neonatal morbidity for twins between 32 and 38 weeks gestation when the first twin is presenting cephalic compared to planned vaginal birth. Planned cesarean section is associated with delivery at an earlier gestational age than planned vaginal birth. And planned cesarean section does not decrease or increase the risk of maternal death or serious maternal morbidity compared to planned vaginal birth. After the subgroup analysis, and I stress the subgroup analysis, twin B is at higher risk of perinatal or neonatal mortality or serious morbidity compared to twin A, no surprise. However, planned cesarean section does not decrease or increase the risk of perinatal or neonatal mortality or serious morbidity of either twin A or twin B compared to planned vaginal birth. Therefore, for twins between 32 and 38 weeks gestation where twin A is presenting cephalic, a policy of planned cesarean section does not benefit the baby or the mother compared to a policy of planned vaginal birth, and planned cesarean section will result in delivery at an earlier age. More research may be required to further explore the optimal management of twins if gestational age reaches 37 to 38 weeks prior to a delivery plan. My final slide is a thank you to the participant countries and members, to the women, and to 3 special people. So they say behind every successful trial or man there's a woman. Well, behind this one there's actually 3 people, 2 women and 1 man. The first is Dr. Kofi Amankwa, who was the chairman at Illinois, who gave me my fellowship job many years ago. Thank you, Kofi. The second is my wife, who's accompanied me through 10 years of trial. And the third is Mary Hannah, who's over there, who took me under her wing and taught me the integrity and the strictness of the scientific method. Thank you, all of you.
We'll start with questions, Dr. Carpenter.
Yes, Marshall Carpenter, Providence, Rhode Island. Superb and encouraging study. Thank you very much. We know that the maternal morbidity associated with operative delivery is much greater in obese patients, particularly delayed dehiscence and so forth. Did you stratify maternal morbidity by BMI?
We did not stratify. Thank you for the question. We did not stratify for that. It will be a good secondary analysis, so thank you for that.
Let's go to the far side.
Fortunato, homeless. If
okay,
we look at
Canada.
the data on the infants delivered by vaginal delivery, it seems like there are a lot more fractures, but you sort of separated out the fractures so that they were not included as a group. If you group all fractures together, does that become significant?
So we didn't do significance on each outcome, on each individual outcome of our composite, simply because of the chance of type 2 error and the small number size. I only illustrated them for you to give an idea of the kind of numbers you would see. But there were, just by looking at the numbers, it looked like there were more fractures in the planned vaginal group, yes.
We'll go to the left side.
Hi, Mike Sokol from Northwestern. For practitioners of my generation, this is a wonderful study, and I congratulate you. But I'd like to ask you a little more about the second twin. And the reason I ask is a very sobering comment for any of us in this room who are involved in resident education. Because in giving board exams, I would tell you that in the United States, if the second twin is non-vertex, at least half of the candidates do a cesarean section. And much worse than that to me is that if you ask those who will deliver the second twin vaginally, what happens if they only have 1 foot? No doubt 1 foot, but 1 foot in their hand, the majority do a cesarean section, which speaks horribly to how we're training individuals here for the next generation. So could you tell us a little bit more about the second twin and how many, maybe I missed this, how many were breech, how many were breech extractions, and also what you do with the second twin if the head is vertex but it's not engaged?
Thank you for that wonderful question, and there's a lot of answers to that. For obstetricians of our generation, this is a wake-up call for us to provide the training of the obstetricians of this generation that the best way to deliver twins is by planned vaginal birth. And I think that's the wake-up call for us as obstetricians. The details of the management of the second twin was left up to the investigator. The majority of second twins that were breech were managed by internal version breech extraction. The delivery interval between the babies was significantly short, about 5 minutes. The majority of internal version breech extractions, more than 99%, were successful. And I'll tell everybody here what I tell my students: if you've got one leg, you just pull and the other one will follow.
All right, we'll go to the middle here.
Hi, Jim Smeltzer from Marietta, Georgia. Beautiful presentation, wonderful study. The late Dr. Patty Hayes, over 20 years ago, reviewed the world's literature and wrote a beautiful review with a little bit of my help. And she concluded, based on the then available data, that total breech extraction was the safest way to deliver a second twin. And did you look at, but there was a timing issue, and the early delivery appeared to be clearly safer. Did you look at those data relative to timing of the second twin?
Yes, thank you, and that will be part of the secondary analysis. And I just echo those comments that the biggest problem with your second twin is placental separation after the first delivered. If you've got a foot, then you can grab something and deliver the baby properly. If you've got a vertex, then you get into trouble of grabbing a head, and you can't. So I agree with that statement. Many of the people in the steering committee and our primary investigators have agreed with this. We did not prescribe that to our investigators, but we will be doing a secondary analysis that will be available. Thank you for the question.
Well, these are great questions, but unfortunately we're running over time, so we'll take one more. Dr. Smith?
Gordon Smith from Cambridge. Congratulations, John, on your study. The only thing I'd really want to emphasize is the importance of gestational age. I mean, half of your babies delivered preterm, and you had primary outcomes of neonatal morbidity and mortality, and the major determinant of that in both your caesarean section group and your vaginal delivery group will simply be that they were born preterm, and the operative delivery is not going to be able to affect that. If you look at your associations at term, you had a strong trend of a protective effect of caesarean section, and the confidence interval was consistent with a greater than 10-fold reduction in your primary outcome at term. So I think you just want to be very circumspect about saying that you have firm data to show that caesarean section isn't potentially protective in twins, because you simply weren't powered to address the effect.
Thank you. Thanks for that important question, Gordon. And yes, pointing out that 50% of our babies delivered more than 36 weeks. And pointing out that the odds ratio of 0.3 is different, as you pointed out, as that's why I stretched in my analysis. And pointing out again that it applies to those babies in which you don't make your plan until that gestational age. And so we have to do a secondary analysis for all the caveats of that. The sample size is small. And it's difficult to know how to interpret that. Does that mean you make your plan at 32 weeks, and then if you haven't delivered by 37 weeks, you make another plan? Certainly the trial did not show that. And rather than get into the intricacies of the subgroup, I think the message must be that for women and obstetricians who are facing twin pregnancies after 32 weeks with a head down, which meant people need to make their plan. If you make this plan of vaginal birth, then these outcomes will be robust. Thank you.
Agard.
Thank you. Thank you for allowing us to present what has been a team science effort. Over the past 350 years, we have begun to appreciate that we are not alone, and rather live harmoniously with not just a limited few microbes, but a complex microbiome. Of the 100 trillion cells in our body, 90 trillion are microbial. At a metagenomic scale, our microbiome outnumbers our own human genome by at least 150-fold, and it is not a silent genome. In 2008, we joined the NIH team tasked with mapping the human microbiome. Completed just this year, we have described that while we inherit 23,000 genes from our parents, our fellow microbe travelers give to us at least 4 million genes, which work constantly on our behalf to manufacture vitamins, patrol for infection, shape and bolster our immune system, digest food, and regulate our metabolism. In our lab, we now strive to move beyond descriptive microbiome science. Our goal is to understand what shapes our microbiome and how our microbiome shapes us. We have shown that the human microbiome varies in health and disease, notably and significantly by body site or niche, and in pregnancy. More moderate determinants of microbiome variation include gender, diet, race, and ethnicity, antibiotics, and disease burden. Of these, pregnancy is a unique window to potentially understand how our microbiome shapes us. With this goal in mind, we hypothesize that the placenta is not sterile, and its harbored microbiome shapes maternal and fetal metabolic and immune regulatory activity and capacity. Our aims were to leverage our human microbiome project developed pipelines to map the placental microbiome and tell us who, what, and how. There are established traditional approaches to mapping the placental microbiome, as well as culture-independent phylogenetic arrays. However, each of these yield an incomplete map at best. Alternately, Direct metagenomic sequencing, while highly data-laden and requiring thousands upon thousands of hours of work, identifies from the DNA footprint both who is there and what they are capable of doing. We utilize state-of-the-science shotgun metagenomics. At delivery, placental specimens from non-actively infected, afebrile term and preterm subjects were collected under stringent protocol. Placental pathology-trained personnel excised 2-centimeter cuboidal blocks free of the placental disc, circumferentially and equidistant from the cord insertion. DNA was extracted under established protocols to yield both microbial and human DNA of absolute highest integrity. This metagenomic DNA is sheared and fractioned to generate billions of random or shotgun clones, which are then sequenced on the next-gen Illumina HiSeq platform, yielding approximately 100 million reads per sample. Sequences are binned and filtered in separate microbial from human DNA and then assembled and annotated. Assemblies are blast mapped against HMP-generated reference microbial genomes to tell us who is there at the family, genus, and species level. In order to understand what can these microbes do, we map to over 90 million proteins and pathways using publicly available computational resources that we and others had built for the Human Microbiome Project. In total, the data I will be presenting today arose from 365 subjects with technical replicates, which generated 1.2 tetrabases of DNA, in total 3.9 with the composite mounts, yielding a placental microbiome map comprised of 728 species from 329 genuses with 2,413 prokaryotic genes across microbial pathways. So who is there and where did they come from? The placenta harbors a commensal microbiome. Graphed here is the relative normalized abundance on the y-axis among only the top 10 most abundant species present in at least half of our 48 whole genome shotgun subjects, each bar representing an individual subject. At a species level, the placental microbiome is largely dominated by commensal or non-pathogenic E. coli species, shown here in the blue, red, and purple fractions, as well as non-pathic gram-positives, shown in the green fractions. Where do these microbes come from? We use principal component analysis, or PCA plots, to reduce then cluster our 16S derived taxa from a total of 317 subjects and plotted the aggregate microbiome profile by body site. When data are PCA clustered by operational taxonomic units as shown here in aggregate, we observe no body site microbiome significantly overlaps, but within sites there is both niche similarity and difference. Notable is the relative proximity of the placenta to the oral cavity with greater distance from gut and vaginal microbiomes. Indeed, when we plot the actual genus-level data from both 16S and WGS sequencing and analyzed by Bray-Curtis as a measure of dissimilarity, where the line thickness denotes the strength of similarity, and 0 being identical and 1 being completely dissimilar, and 0.5 is significantly shared. We observe overlap only between the placenta and oral microbiome. Note the strongest similarity persists within body niches, such as shown with the vagina, where the posterior fornix, the mid-vagina, and the vaginal introitus in subjects is somewhat akin, but not identical. When we alternately plot our aggregate data by phylum to genus level projection, we observe differences at close sites, such as placenta, vagina, and gut, underscoring that our observations are highly unlikely to be due to contamination at the time of delivery. Greatest diversity is confirmed at family, genus, and species taxa from inner to outer aspects of the phylogenetic wheel, noted as nodes, and plotted as average abundance of species here by the upper panel and family in the lower panel. This is true across body sites. In these panels, counts are aggregate so that the size of the circle is thus directionally proportional, again demonstrating the uniqueness of the placental microbiome from all other body sites we have sequenced. What are these placental microbiota doing? The placental microbiome is not just a silent traveler, but retains metabolic capacity. Plotted in the upper panel are per subject relative abundance of the 10 most abundant phyla in the human body, and on the bottom panel are their gene catalogs mapped to our 9 million proteins in their KEGG metabolic pathways. The placental prokaryotic gene catalog contained nearly 2,500 genes. We observe a significant increased relative abundance of genes for the metabolism of cofactors and vitamins, nucleotide metabolism in the purple bars, and decreased amino acid metabolism. If we alternately plot the most abundant species in the upper panel and metabolic pathways in the lower panel in a dendrogram fashion showing relatedness by cluster of the dendrogram, we again observe that the placental species are shared with the oral cavity, as evidenced by the shared count and row z-scores on the heat map, where red is a threefold log abundance higher and blue is lower. However, when we plot metabolic pathway, we see that although the placental microbiome carries distinct metabolic pathways, again demonstrated with significant clustering separate and dendrite from all other body sites, it is closer in function to the vagina than the mouth. This is good. The most abundant and significantly distinct metabolic functions of the placental microbiome include purine and thiamine metabolism and, not surprising to many, oxidative phosphorylation. Interesting is our observed diminished microbial glycolysis and gluconeogenesis, potentially a means of regulating pathic bacterial growth. How is the placental microbiome shaped? When we plot genus-level PCA plots from each of our 356 individual subjects' placentas, we fail to observe clustering by obesity, as shown here, in the lack of separation between red and gray dot clusters, nor by vaginal group B strep status, nor whether they underwent a vaginal or cesarean delivery, underscoring that our findings are highly unlikely due to contamination. However, when we alternately plot by a history of infection in the antenatal interval, defined as any time in the first or second trimester, we observe significant clustering. The vast majority of these antenatal infections were urinary tract infections or pyelonephritis, but also included rare chlamydia, syphilis, which was treated, bacterial pneumonia, tooth abscess, several cases of periodontal disease, and urosepsis. All chorioamnitis by study definition were excluded. This effect is again demonstrated at the family level with our left-C analysis, where we see significant variation in placental microbiome profiles with least discriminant LDA scores exceeding 2.5-fold log, shown here as the red bars denoting antenatally infected remote individuals. As an initial measure of potential clinical relevance, we asked whether we could use these aggregate placental microbiome profiling to accurately predict any aspects of the index pregnancy employing supervised learning pipelines. While BMI, mode of delivery, and GBS status were no better than a flip of the coin with an average rate of 50% at any taxonomic level, the placental microbiome profile at genus level not only 65% predictive of remote antenatal infection, but importantly, of preterm birth at less than 37 weeks. We conclude that the placenta is not sterile, but in fact can be reliably mapped and demonstrated to be metabolically and antigenically vibrant, somewhat akin to the oral microbiome. A remote history of maternal infection shapes the microbiome community in our placentas. There are multiple potential implications with our placental microbiome work, including clinical implications such as long-known associations between periodontal disease and urinary tract infections with preterm birth, as well as future questions relating and pertaining to maternal and child health. I would like to first and foremost acknowledge an incredible cadre of investigators, both at Baylor College of Medicine, including members of my lab, such as June Ma, who led an incredible bioinformatics effort, as well as my close collaborators from the Human Microbiome Project, including Drs. Jim Versalovic, Joe Petrosino at the Broad Institute, Dirk Evers, and Curtis Huttenhauer at Harvard University. I have to acknowledge my funding through the National Institutes of Health, which has been incredible to promote this level of innovation in science. And finally, in the spirit of Valentine's Day, I'd like to thank Dr. Jim Versalvik for being my partner on this once-in-a-lifetime scientific journey. We met at the start of the Human Microbiome Project, and 5 years later, he proposed on the day that our back-to-back Nature papers were published, which is real incentive. As noted by Dr. Francis Collins on hearing of our engagement, science is so much more than cold and soulless activity, and is best when done with a love bug and a real spirit of adventure. With that, I would love to take any of your questions. Thank you.
Thank you, Kirsty. I was waiting for someone to say Happy Valentine. So Happy Valentine
George,
to both
happy
of you.
Valentine's Day. Thank you.
Yes.
Harvey Kleiman, Yale University. Did you do matched analysis with the maternal blood from each of these cases? Because, of course, the entire intervillous space is filled with maternal blood.
No, we did not do matched analysis to maternal blood. That would be a very, very difficult study to do. These are not free-floating bacteria. This is not sepsis. So we'd actually have to target out several ways. We believe this is truly limited into the placenta at the level we have detected it. You are correct that we believe that the way it actually becomes potentially seeded is through the blood, but that is different than saying that we can pick it up within the maternal blood at full term.
Yes, sir.
Adam Urato from Tufts University. I'm curious, that was a great presentation.
Thank you.
I'm curious, though, where you would suggest that this biome is active. Is this within the stroma of the placenta? Is it maternal surface? Is it the fetal surface? And you said several times during your talk, this suggests that it wasn't contamination, but can we really be sure? If we're recovering the placentas, it has to be a human endeavor where there's an opportunity for contamination, and how can we really be sure unless we're going into the stroma and not dealing with surface?
Right. So I have two answers to that question. The first of all is I'm actually going to refer to some really, really outstanding work that's going to be coming out from Washington University and Dr. Indira Mayasikar's work. She'll be presenting, I know, some of this as abstract 14 later today, but she's demonstrated that intracellular bacteria are present at the maternal-fetal interface and in the basal plates of both preterm and term gestations in about a third of all cases. So here's evidence that's hard to refute as contamination. You're looking in the intracellular spaces within the placenta. The second question about contamination is I can say with a great degree of certainty this does not prove to be contamination for three reasons. First of all, we're analyzing in parallel both the vagina and the stool, which would be your most likely sources of contamination. And we do not see similarities at the species level, at the genus level, at the family level. We have to go out to the class level to see similarities. That would be 1 in a billion odds that we would be able to pick up species that are truly distinct, that we only see similarities at the class level. The second line of evidence is that we are very stringent in how we collect these placentas and the way we do them and the way we treat them. And we do go back and do validation by qPCR in other tissue sample specimens, and we're finding the same genus and species level representations in our validation specimens, also suggesting that this is highly unlikely to be contamination. The third aspect that would suggest is not contamination is that we don't see a difference between cesarean and vaginal birth placental specimens. If we felt this was contamination was occurring at the time of delivery, that's when we would expect to see some level of bifurcation in the data that we just don't see exhibited. But it's a really, really great question and something we have struggled in the 2.5 or 3 years we've been doing this work to make certain that we are not reporting erroneous contamination. Thank you.
Thanks very much.
Thank you. Next, last question.
Dan Farin from Toronto.
Yeah.
In view of the Oracle 2 study, when
Yeah.
antibiotics was really bad for you,
Absolutely.
did you try to distinguish between the effect of early infection or the therapy of those early infections?
Yeah. So we've been long intrigued by the Oracle study, and for those that aren't familiar, they basically showed that there's a increased risk of necrotizing enterocolitis in infants that are exposed to some level of clavulanic acid in the context of treating PPROM. And so we've been very intrigued by that because clavulanic acid is a bit of a sledgehammer to one's microbiome. We actually only had 2 people within this study that were ever treated with Augmentin for their UTIs, and we didn't see anything fall out. Remember, we are looking at literally terabyte levels of data. It'd be like if this whole room took their iPhones and their iPads and put it in a big pot and used all of those CPUs to conduct this. So if there was something there, it could potentially be masked by the massive amount of sequencing noise that we have going on. I don't think so, but it's something we're very, very interested in looking to the future, because I think you bring up an outstanding point. Thank you for asking that question.
Sure, Steve. I'm glad shotgun is being used for good use.
Yes,
and,
especially in the state of
Is there a
Texas.
background check or a waiting period before you use it?
This is the kind of shotguns we like.
Thank you, Shirley. Before you all leave, I was